Again, I'm David Kotz, and I'm very happy to chair the third panel session today. This one is focused on opportunities for mHealth in the developing world. This photo on the slide is actually from India. It's not my picture. If I think for a minute, I'll remember the name of the grad student who took it. She was working at Microsoft at the time. I just want to give a very brief, quick overview. Many of you are already have expertise or experience with mHealth in the developing world. But for those who don't, I'll just give a quick overview and then leave it to my more esteemed panelists to fill in some details. So one of the things that has really pushed more activity in this area, it was a report actually a few years ago, I think about 5 years ago now, by the UN Foundation, the Vodafone Foundation. This stuff has been going on for a lot longer than that, but it has, I think, awakened a lot of people, including myself, to the opportunities for mHealth in the developing world. And the main issues, as I see it, are really improving access. So many people, billions of people in this part of the world, don't have access to healthcare, or at least inadequate access to healthcare. And, of course, lowering costs, making it more efficient to deliver quality care to people who otherwise wouldn't be able to afford it. And the other text on this slide is a list of some examples of ways that mobile technology might be useful in helping with healthcare broadly defined in the developing world. So just as a couple of examples, in-hospital workflow support. So you might use mobile technology. These pictures are obviously very old, as you can see from the technology. You might use mobile technology in support of clinical activities within a hospital or clinical setting. You might use them as a data collection tool. So you might give them to health workers or survey workers of some kind who are going into the community, collecting information about health issues, spread of disease, and that sort of thing. You might use it for behavior change communications. Many of the examples that have been tried involve using SMS technology, for example, to push behavioral messages about HIV or other sort of drug use and substance abuse, that kind of thing, to the community. Another is just sort of awareness-raising campaigns, again, pushing information to the community to help people better understand some of the risks or issues involved. Decision support is another example way of using mobile technology in support of health workers, particularly those who are physically disconnected from a clinic. They maybe are rural health workers who are going house to house or village to village, and helping them, who may not have deep medical training, to interact with individuals face to face and giving them some support in helping them understand how to react to a given set of circumstances. Sort of extending that to somewhat is remote diagnosis. So using these information and communication tools, and possibly extended with sensor technology, to collect medical information on the spot in perhaps remote places, and then transmit that back to some expertise in a remote hospital or clinical setting where the expertise can help with diagnosis. And this can be useful, for example, in dealing with the access problem, because for many of these people, it requires often days of travel to get to the closest hospital, and it means losing a day or multiple days of wages in order to do that, and of course the extra expense of transportation and so forth. So if you can push the expertise in a virtual sense out into the community, you can improve healthcare. A sort of fancier form of that is telemedicine into remote clinics. So one of my favorite examples is the Aravind Eye Hospital in southern India. Dr. Aravind has actually been here at Tuck many times, somebody I know quite well, and they have a very innovative model for providing free eye care, in particular eye surgeries, to the people of that region. But in order to scale beyond the set of people who are sort of within a half day's travel from their hospital, they needed to create a lot of clinics out further into the villages, again, to make it easier for the people to interact with them. And they couldn't possibly train or hire enough skilled physicians to put in every clinic, so they do that through telemedicine. Another form of this is a mobile clinic. So if you can't afford, for whatever reason, to set up a clinic in every village, then maybe you can make a clinic on wheels. This is one example. Actually, Aravind does this and many other organizations as well. And of course, there are times when the health situation is a sudden and large-scale event, a hurricane or an earthquake or something like that, and you need to move in a lot of expertise and technology very quickly, and mobile health can help with that. And of course, this one may be more familiar to those of us in the first world, remote patient monitoring. So if you have a patient in a remote location and it's difficult for them to come back for checkups or for occasional care, you can monitor them through technology in their home or in their village at least, and make it easier for them to know when do they need to come back, when do they need to take the extra effort to come back to the clinic or hospital. And finally, epidemiological kind of things. If you're trying to understand how a disease is spreading, if you can use mobile technology in the hands of workers to track incidence of disease. So those are just some examples of how mobile health technology is used and can be used in the developing world. And I just wanted to highlight a couple of trends that many people have noted before me. One is the massive penetration of mobile phones in the developing world. In fact, in some places, a higher percentage of people have mobile phones than in the developed world. I'm not actually sure. I found this statistic today, that a prediction that by 2014, more than 97% of people in India will have a mobile phone. That seems a little high to me, even though the penetration there is already very high. I think it's well over 75%. But it's very large in any case. And we're talking, over 1 billion people with mobile phones. Not necessarily smartphones, but mobile phones. Of course, going with that is wireless connectivity, which is pervasive. Not comprehensive. There are still many places in the developing world, including Hanover, New Hampshire, that don't have good wireless coverage. But it's coming, at least we think. So the other thing another trend that's kind of interesting, at least in India, which I know best, is the shifting health needs, actually. A lot of the developing world health challenges for the last 50 years were centered around infectious disease and problems related to that. But increasingly, actually, as the societies develop, they are developing, unfortunately, many of the lifestyle diseases that we in the developed world have been experiencing for a while, seeing more obesity and the complications that come from that, like heart disease and diabetes and so forth. And there's actually a great concern that diabetes will be a major, major problem in places like India in the next 50 years. And so with that brief overview, certainly not comprehensive, I want to introduce the panel. And I'll start, I think we're just going to go in alphabetical order here, for lack of any better alternative. So I'll start by introducing David Aylward, who is from the Ashoka Foundation. He's a senior advisor of global health and technology there. And previous to that, which was a couple of years ago, I guess, he was the director of the mHealth Alliance, the first director. You met Patty last night, who's the current director. Prior to that, he was, among other things, he led the staff of the U.S. Telecommunications and Finance Subcommittee during a particularly exciting time, the breakup of AT&T and the advent of a lot of today's telecommunications legislation. What else? He was the director and chief strategist of the nonprofit organization ComCare, which is an emergency response alliance, and which included technology, as I recall. And probably most important, he has an undergraduate degree from Dartmouth College. So, David.
Thank you. It's delightful to be back here, although I'd never been in this building. When I graduated in 1971, there was a small war going on, which got our attention, and we didn't spend a lot of time down Tuck Row, more Robinson Hall and other places. But I'm delighted to be here, and thank you, David. David's been a good friend since we found each other. He was on sabbatical in India doing maternal and child health, and I was trying to do maternal and child health. I'm now at Ashoka. If you don't know what it is, before my time, they coined the term social entrepreneur, and we have a wonderful collection of 3,000 Ashoka fellows around the world, of whom about 600 are in health and wellness. And so we have this kind of unique window on the base of the pyramid and what works and what doesn't work in different environments, which is a wonderful base to do what I get to do, which is to help lead two programs, our Nutrients for All program and our Health for All program. As the terms imply, we are focused on those that don't have and need, and the kinds of things that we're trying to invent really need the expertise of people like you, because the number one thing we need is not technology. I assume the presence of technology. What we need is effective business models, how to deliver this care at numbers that the last panel wouldn't even think about. We need to get into orders of magnitude of cost below those, and hopefully orders of magnitude of result better. Oh, okay. Well, there we go. There we go. So we have two programs that I'm involved with that Ashoka is trying to bring together, both its fellows and others, I stress, and others, to transform two separate ecosystems, which we think need to come together. The quick summary of the one that's moving horizontally is we have a food chain that has ceased to perform its function as a nutrient delivery chain. It, in fact, is doing the opposite. It's a calorie delivery chain stripped of most nutrients. I'm not going to spend a lot of time on it other than to say that it's an interesting process, and if you're interested at all in agriculture or food processing and so on, I'd be glad to introduce you to people who are doing that. I'm dealing with the result of it, which is that we are creating very, very sick people in this country, in India, and everywhere else. And your comment, David, about diabetes, 30% of the males over 30 in Hyderabad are headed to type 2 diabetes. So there is a crisis in part because of food, and our medical system is beautifully set up to deal with the expansion of sick people that's creating. They're not set up at all to stop it, to deal with it. And so what we're focused on is, all right, so if we get really good nutrition, if we can get nutrient products, fully nourished foods into people, that isn't enough to make people well and healthy. How do we deal with a move from a sick care system to a well care, to a system whose target is not keeping people alive, but whose target is vitality and creating vitality? And initially, to get there, we want market solutions. This is a chart my colleague Al Hammond did based on the only study that's ever been done segmenting the base of the pyramid by spending. These are 2008 dollars, and there's basically $5 trillion a year in spending by 4 billion people who are left out of the formal economy. Most of it's going to food, as you can see. The ICT corner there has expanded enormously, although we don't know exactly how much, because the wireless industry said, yeah, they're poor, but they will pay value. If we can go in there with a low-price product, a $20 phone, and inexpensive minutes, prepaid, we can create a market, and they did. And so that one's expanding. Health is a very big one. So these are real consumer markets, unlike the U.S. healthcare market, which is not a consumer market at all. You come up with a great idea that delivers better value at a lower price, God help you. But hopefully in these markets, there's an opportunity to really come up with those kind of products and sell them. Because the people are paying for healthcare in the countries that I work in, but they're not getting very good healthcare. So all over the world, though, what we have is what I'm going to generously call broken, dumb healthcare systems. They're dumb because there isn't good information flowing. There's not good information flowing amongst the participants, to the participants, from the participants to the researchers. When people, the systems don't work well, they don't work very well here, although I'm a new patient of Kaiser's in Washington, and it works really well. It's very convenient, I found, unlike the health system I had before. But in most instances, we have systems that are either overwhelmed or overcharging, and in almost every case, they're subject to a massive information failure. So as you technologists and you information people think about this, recognize that it's not an mHealth problem. I mean, mHealth isn't the solution here, but information is part of the solution, a big part of the solution, and mobile makes things possible that were not possible before. It allows the transformation, but it's the transformation that's interesting, not so much the particular methods of it. But we don't track interventions. We don't have metrics for nutrients. Who knows how we measure full nutrition? Anybody? We don't. We don't. I want you to be fully nourished, but we don't have a quantitative measurement of full nourishment. We measure iron. We measure D. We could measure kind of anything you asked us to, but we really only measure 4 or 5 things in public health. Because, why? Well, because that's what we've done, or because that's what we can do, or because that's what we've always done. We don't have vitality. The mental health people have very good measurements for depressed to suicidal to dead. You know, they go down. But if you ask them, can you go up? Can you? They look at you like you're weird. Well, I've had this conversation with behavioral health people, and they say, what do you want? I said, well, at college we had B's and A's. You know, you just have C's to F's. This is not fair. We don't focus on outcomes and efficacy. We don't have accountability. We have all these systems where Gates gives a lot of money to an NGO. The NGO goes out and hires a bunch of health workers. They train them for a week. They send them out in the community. And can I sit at a terminal in Hanover and watch them move around and look at the data and see whether they went? No. Why? That doesn't make any sense. Research and data mining, every program I know about has to have a research component. I asked some academics, what does it cost? They said it costs 15%. I said, what? And they said, that's the standard. The research should be 15% of the program. I said, yeah, but I'm going to give you all the data for free. And they said, how's that? I said, because we're going to produce data from our operations, because we're going to use mobile health, and we're producing data as a, so you don't have to do any data, you just have to do analysis. They said, well, 15%. So, and then it takes more than 10 years, somebody used the number 15 years for the US from knowledge to half deployment with doctors. I mean, the path that you folks have imposed on progress is just extraordinary. We do a study, and the N is 50. I mean, you know, Sarah, you got to get bigger. And then you put it in the Lancet, and then somebody else does a study of 200, and then they do a study of 2,000, and, you know, it's just, and then there's no sustainability in scale. So we can revolutionize all of this. This is one of the neatest meetings I ever had. You've heard of microfinance circles that Muhammad Yunus invented. This is one of his, and the hand right in the corner there is the woman who went to Stockholm with Yunus to receive the Nobel Prize. And this is her village. There's no electricity. I had to walk half a mile to get in here. And this is the answer to my question, who has a cell phone? Boom. Everybody has a cell phone except the women in the middle who are the poorest people in the group. But there's a pathway, and I assure you, the coverage and signal strength beats the hell out of the one in lose. I mean, they got much better coverage than you do. So there's a vision here of how we can change this, how we can inject technology, use technology as a revolutionary method to fix this system, to make it smart. But we got to have a different goal. Who knows what the Millennium Development Goals are? They're all about saving lives. The metric is saving lives. Congratulations, we're saving lives. You've seen some of the people's lives we've saved? They have no chance to have a good life. Their genes have been screwed up by malnutrition so that they will have much higher rates of diabetes, and their children will. So we're creating these generations of people with no hope. We have the wrong goal. And we need to move from a sick care system whose success rate is keeping people alive beyond wellness to vitality. And if we do that, if we say our strategic mission is vitality, so that these poor people cease to become poor people, they can change, they can learn, they can operate, then we're going to design very different systems. And we can use ICT in and outside of this. Don't get me wrong, my field is communications. I love technology. I think we just need to put it in the service of these goals. Because as my friend Joe Tornello pointed out in the last panel, just because you've got a terrific IT solution doesn't mean that you're not just going to move the deck chairs around. But one of the most important, perhaps the most important, is empowering the public and frontline workers with information. I had the pleasure of sitting next to a woman this morning who's working on reproductive issues. And what's possible now is to get information to 14 and 15-year-old girls that they don't have to do what the men in the village tell them to do. So there's this opportunity to empower women particularly, but also those frontline workers, those people that are sent out there. Medicine is not an art. Health is not an art. It's a science. And if it's a science, then we're going to go to checklists, and we're going to go to protocols, and we're going to do best practice. And if you don't do best practice, you don't get to work for us. And we're going to know you did it because it'll be a checklist, and it'll be on the tablet. If you're an engineer and you build bridges, you don't get to do it kind of this way. At Thayer, they make you do it in a certain way with equations. Okay, well, we can do healthcare that way as well. So everything's on a protocol, and because we're doing it mobile, it means we can record it. Because we have all these wonderful sensors, we get real data without human error in them, which allows us to have real-time management of systems for the first time, real-time feedback to people in the field. And by the way, our field experience is that poor people love seeing these sensors playing into the tablet and feeding right back to them. They get really excited about it because they're getting real results. So in a distributed kind of system, we need to focus on the bottom of this pyramid. The top is taking care of itself. We need to focus on the public, trying to achieve wellness with integrated systems, doing nutrition, health, water, public information. Lots of breakthroughs needed. The most important one, and I'll stop here, is who benefits? Who's going to lead this change? It is not going to be hospitals, because hospitals are sick care institutions. They will not benefit from this. It will not be government, because government never leads anything anywhere. That's not a criticism, it's a fact. We need to create models for the government to copy and invest in. And so we need leaders. We need people who are going to make money by keeping people well. So the thing I hope we can figure out, and that we at Ashoka are working on, are what are the models for workforce, for schools, for moms and babies, where people will make money by keeping them well. Thank you very much.
Great, thank you, David. So our next panelist is Hamish Fraser, who is an assistant professor of medicine at Harvard Medical School. Here at Dartmouth, we don't like to use the word Harvard too much, but that's all right. Thank you for coming. And he's a research associate at Brigham and Williams Hospital as well. He trained in general medicine, cardiology, and knowledge-based systems in the UK. And he also was director of the Informatics and Telemedicine at Partners in Health, which is another organization based in Cambridge, Mass. And it's very interesting to me, at least, he was co-founder of the OpenMRS initiative, which created an open medical record system, open source medical record system, which actually we're using in my lab. So, how much? Thank you.
So I'm just going to really touch on a lot of major initiatives that we're doing. So please forgive me for jumping from one thing to the next, and I'm very happy to obviously take questions about that. I'm slightly cheating here by calling OpenMRS mHealth, though you can install it on a mobile device or a tablet, but it's part of a larger environment that I think you'll see from the discussion. So what I'll do is really just talk a little bit about OpenMRS itself. It's an open source electronic medical record system, and then talk a bit about some of the important issues that have come up in discussion here and other places, one of which is standards and interoperability. There's also the question of open source and open systems in general, and also discussion briefly about evaluation and why it's important to really understand the impact of these systems. So, first of all, electronic medical record is one of the core technologies that we've discussed here today, and then really required for a lot of the work that goes on in healthcare facilities, but it was also increasingly something that people are able to use in a community or setting or even in patients' homes by being able to access the data. And I think one of the key points is not only do you have the mobile device that allows you to get access to that information and to manipulate it, but that there is a place where that data is stored and managed, and that it really needs to talk to other systems as well. So in other words, the mobile device on its own is obviously not that helpful compared to the system that can access data from EMR, from laboratories, from pharmacy systems, and so on. So we use this data for a number of things. Clearly, clinical care and quality improvement are absolutely core to the work we do, but also reporting, and that could be to clinicians to indicate problems with patients or to show them what the outcomes are, or just the case mix, but also, of course, to managers and to funders and so on. Another area which I found was very important when I started working originally in Peru was logistics and supply chain, and the ability to forecast drug requirements, the ability to track shipping, and also to monitor the inventory in different locations, particularly in smaller and remoter places. And then finally, clinical research is also a high priority. So OpenMRS really came out of a number of projects. In particular, I'd been working with colleagues like Darius Jazieri at Partners in Health to develop a web-based electronic medical record system for management of drug-resistant tuberculosis initially, and then we moved on to working on HIV care in Haiti. And so we realized after then taking that system for HIV care and putting it to work in our new project in Rwanda, that it was really, even within one disease area, it was challenging to kind of adapt these systems to new environments and new working practices. And then we really needed a more general purpose system. And our colleagues at the Regan Street Institute, who'd been working with the AMPAF project in Western Kenya, had been building electronic medical records using Access, and they had built a pretty successful system, the Masoriot Medical Record System, and then the AMRS, or African Medical Record System. And they were interested also in building a more general purpose system, and had come up with some designs for that. So we got together also with a colleague from South Africa, Chris Siebrecht, who was working at the time for the Medical Research Council, said, well, we need to actually build a common platform. And this ended up being the OpenMRS, or Open Medical Record System, and it uses really a very open design. It's actually got a concept dictionary for data storage, which means that instead of hard-coding all the data items into tables in the database, you have a data dictionary. You can modify that relatively easily. But more importantly, you can actually share those data dictionaries, and you can map them to standards and so on. The system is also modular, and that's been a critical issue, that as well as being open source, the key thing that lets people innovate most effectively is that they can plug in modules that do anything from creating a specialist form or a workflow, doing a particular analysis, or interoperating with various other systems, which could be anything from a device to, say, supporting an HL7 feed from a lab system or to another system. We released the original open source license about 2007, and what we have is a fairly large core of paid programmers working for Partners in Health, for OpenMRS and the Regan Street Institute, and then organizations all over the world, including GEMBI, which is in South Africa, which took over from where Chris was working at the Medical Research Council, and also a number of projects in India and many projects around Latin America and other parts of Africa. So this community has really grown enormously quickly, and it's been very exciting to see that grow, and also challenging figuring out how we actually make that work, how we really adjust our focus between supporting the core code base and also supporting the sites that actually want to implement the system, and how do you ensure that the core system is flexible, but at the same time improving the quality of the tools, for example, for clinicians and other healthcare workers to interact with the system. This is just actually a limited number of the sites. A lot of people haven't filled this map out, which is, I keep trying to figure out how to get more people to fill it out. There are actually a ton of projects in India, so before someone points this out again, it's actually probably got more than anywhere except Africa, but for some reason people haven't filled that out. So this is an example of somebody using the system. This is one of our clinicians in Rwanda, in the eastern part of the country, managing an HIV patient, and they're able to look up the patient summaries. And that data is important for a number of reasons, one of which is because HIV is a chronic disease, of course, it's a lifelong treatment. You need to be able to see what the previous condition of the patient was, what drugs they were taking, what their CD4 count is doing, which is the measure of their immune system response to treatment, for example. And so this has been helpful for people to be able to look that up. We also use consult sheets, and in fact, from the earliest stages in 2005, we've been printing out these sheets, and there's really a row for each patient. And before the clinic, they have these sheets, and they can look at those. And you can see, for example, that there are little alerts here that warn people about declining CD4 count or low body mass index. And this information is actually pretty important, and I'll come back to how we're using that. This is another example of an implementation of the system, and this is actually a Lacoline hospital in rural Haiti. This system has been adapted in a slightly different way, having started really with a focus more on HIV and drug-resistant TB and the chronic disease management model. This is actually looking at episodic care. It's really kind of all the primary care visits for the clinic. So every patient that comes, they get a barcoded ID card printed out from the system. They are registered. If they have health insurance, that's recorded. And then we can record the diagnosis. And this just shows a coded diagnosis recording tool. And so what this is doing is creating a very thin layer of information about everybody who comes in and providing them with a secure ID. And that ID, in some countries, will, of course, be a national ID. In Haiti, it's not quite ready yet for that. But it means that we can then see these patients coming back and build a foundation that allows us then to hook on other information. For example, one of the projects our students have been doing this year is looking at recording the outcome for surgical patients in one of the other hospitals in Haiti, near Valley Hospital, and seeing, for example, if the wound is healing well by using an mHealth tool and actually using Sana, which I mentioned earlier, to actually photograph the wound and then provide some information. So that's the plan, is that we'll then be able to follow these patients up and see what the actual outcome was. This is just a simple example of using some of that data from patient registration in Lacoline Hospital to see where patients are coming from in Haiti. And this is going to be particularly important with our new hospital, which is a teaching hospital, because that will have a very much wider catchment area. It's going to help us to understand much better where people are coming from and what proportion are coming from the capital Port-au-Prince, which is probably going to be pretty big, actually. So, a little slow. Okay. So, standards and interoperability. I have a quote which my colleague John Payne, who is one of the experts on interoperability in mobile health, has been using quite a lot, which is that standards are something that's very important. They're difficult to do, but no one really wants to do them. And I said, basically, they're like plumbing. You really need them, but not everyone has a passion for it. But if we don't get this stuff right, then all the other pieces don't work well. Now, I know that some people are very passionate about standards, so I realize I'm treading on some toes here. But I think it's the key thing is that when you start off, you often start with a smaller project. You're trying to focus on a particular clinical problem or research problem. You are focusing very much on the workflow for that particular problem. And you can do a really good job often in mapping that and providing good support for people. But as you start to expand that, either in geographical scope or covering more diseases or just expanding the number of patients in the system, you rapidly begin to realize that the very specific systems don't work so well. And one of the big challenges is this whole question about standards, and how do you then actually map that data that you've collected to other systems or compare the outcomes in different countries or different sites. And so this has been a big issue for us. And in fact, we kind of worked that pathway with OpenMRS from people really building their own concepts in the concept dictionary to increasingly curating that into a standard dictionary called the SEAL dictionary. And Andy Cantor from Columbia University has actually been taking the lead on that and doing a really amazing job and linking that to a number of different mappings for standards from a company called IMO, which he also works with. Another thing we're doing is what's called the Maternal Concept Lab, and that is actually looking at how do we create this core data dictionary which can actually really be used not only to share data between sites, or at least compare the data between sites, I should say, but also allow us, for example, to plug in the same decision support tools or the same reports, because the mapping is good enough that you can actually then reuse those artifacts as well. And that's a critical next step. We also look at interoperability with a variety of mobile health software platforms, and we've been working on a number of organizations that have open source platforms, because I think that's a very important issue. I mentioned the modular architecture. And then finally, there's also a modular architecture that's been developed at the Children's Hospital Informatics program in Boston that is looking at how we can actually create modules that can plug into US-based EMR systems called SMART. So this is an example of some of the mobile health platforms that talk to OpenMRS. And so we have Sana, MIT, which I work with as well, University of Washington's Open Data Kit, Comcare in Cambridge, who do really good work with particularly with community healthcare workers, and then OpenX Data, which is used a lot in India and Africa as well. This is just a quick example of the smart apps, and OpenMRS supports the smart framework, and there are a few other systems that are starting to do that. And we think in future that could really make a big difference for people being able to innovate and to actually plug in new tools into existing EMR platforms. So just a couple more things to go, really. One is this whole question about open source and open development. And I think for us this has been a very critical issue, and something that we spend a long time explaining, justifying, and then also learning a ton of things, often making mistakes, backtracking a little bit. But in the end, what we found is that this open source approach has been very powerful. It's allowed us to create a community which is now working in more than 50 developing countries, maybe 60 actually. And it's now scaling to the point where there are national rollouts going on in Rwanda, Kenya, the Philippines, and soon probably Nepal and Bangladesh and other countries. The modular architecture has been as important, I would say, because that's allowed a lot of innovation to occur. You can build your own module and you can make your own mistakes and try stuff out without breaking the core system, and that's a very, very critical thing. I mentioned the concept dictionary and the fact that we can share outcomes. One of the things that's come up recently, which I think is interesting in the context of discussing security of data, is that in the US context, HIPAA has sometimes been a barrier to improving these systems, like EMR systems, for example, because it's a way of avoiding actually sharing the de-identified data from systems, sharing what's actually happening, for example, having registries of errors and problems that occur with systems so that we can improve them. And by having a very open approach, it means that if something doesn't work, you can drill down to the point of even looking at the individual lines of code until you really pin that down. And I think that could be a very important issue going forward. And so that's something which I think, when you think about security, it's not just about how do you protect patient confidentiality. You also have to trade off, are there uses of data that are actually important for patient safety that are being constrained by that? A couple more things. Just one thing I wanted to finish with really was the fact that evaluation is a key issue, and for a long time we didn't really have very good data on what systems worked and what didn't. And I bring up this particular study because it's one which has just been published in Pediatrics about 2 months ago, and it's the first randomized controlled trial which is actually looking at the impact of reminders on care of patients in Africa, or at least in a low-income country. This was done by Martin Weary, a colleague at AMPATH. So they have OpenMRS used for their pediatric HIV patients as well as the adults. And they wanted to look at whether printing summaries with alerts and reminders, a little bit like the thing I showed earlier on, would impact on the quality of care. And what they found was that for these different items, the DMA polymerase chain reaction, which is what you use for testing for HIV in infants, CD4 counts, ELISA tests, radiographs, and other tests, that for each of these, they looked at whether providing alerts and reminders printed out for the doctors would make a difference. And they found there was a really pretty big difference in 1,611 patients, that there was actually a 4 times increase in the providers responding and actually taking the action. 68% in intervention versus 18% in the control group. And so this was really a very significant difference. It doesn't yet show an impact on patient outcome, which is the next step, but I think it really shows that well-used these systems can actually have a real impact on things that we know are items or actions which will make a difference to patient care. Okay. And so finally, just to say that this is another area of scale that's going on with OpenMRS, and this is the Mir Valley Teaching Hospital in Haiti that just got opened about maybe 6 weeks ago. And there what we have is a new version of OpenMRS, which has a much better user interface, and it's now being used as sort of a hospital-based system for a big teaching hospital. And we're working with ThoughtWorks, a large software consulting company, and they're also working with a hospital in India called the JSS Hospital. And so we're now starting to scale hospital-scale direct patient care interaction type of systems. So that's our sort of next big push. So thank you.
Thank you, Hamish. Our next speaker is Ashu. So, Ashu Sabharwal is a professor of electrical engineering and computer science at Rice University, and he has a long history in really innovative engineering projects, and most recently including several interesting medical devices, which I imagine he'll be talking about. He also there is leading the new Rice Scalable Health Initiative with the Texas Medical Center.
How's everyone doing? I was feeling a little bit sleepy there. Food plus warm room. Yeah. India, yeah. Or Houston, yeah. So actually, I'm an engineer coming from a actually wireless communications background. So the chip which goes in here, which lets you talk to your cell towers, what actually my main area of research is. And I guess perhaps because we are across the world's biggest medical center and through osmosis, or perhaps Rice trying to merge with Taylor College of Medicine, we all somehow got involved into health. So I don't have a good story how 3 years ago I decided to work in health-related areas, but here I am. Every time I go to meetings which are more health or medicine related than engineering, it's very educational, mostly because I don't know any of it. But they're also very depressing, actually. So I have to be, and the more important thing as an engineer, I mean, I get over the depression part at the end of the day with wine, cup of wine, a glass of wine, but is that I found that I am not inspired to work in it. And mostly because sometimes I cannot translate into what I can contribute. Okay, so these few slides I have is my attempt of listening for last 3 years, not just in the US, in Texas Medical Center, but also traveling in India, talking to many people, ranging from rural healthcare workers all the way to urban hospitals, and trying to extract engineering problems which will excite engineers. What is our next moon landing? So we essentially need something like that for a lot of engineering people to come in and start innovating. Okay. So at the core of healthcare is patient data. Okay, so that I hope nobody denies that. I know there's security, safety, standards, everything is important, but if you don't have reliable data of the patient, then you really can't do anything. Okay. And I guess in mature healthcare models, we have protocols to ensure correctness. We have a lot of training to ensure accuracy. So we have technicians for almost operating every equipment. And then I think you throw in right incentives and accountability, you get a reasonably good model. It's not perfect, but it's better than, for example, this anecdote I heard about an urban hospital in Africa, which is a neonatal ward. I won't name the country, but so this is a ward where there are babies which are not well. That's why they are in the hospital after birth. And then if you look at their charts, every morning, their hourly respiratory rates are all 40, 40, 40, 40, 40, 40. That's the normal respiratory rate for a baby. Okay. Impossible. Anybody who looks at this chart knows that actually the nurses actually didn't do their job. Okay. Now, there were many reasons given for this, but that's the reality. This is an urban hospital in actual Africa. Okay. So I hear this. Then I started thinking that pretty much all the medical devices we have are really not very smart. They are designed from ground up by relying on trained, sincere, and well-incentivized staff. That means a human worker is actually crucial for their correct operation. Okay? So really, when we started rethinking devices, we had to decide we're going to impose our devices to think. Our devices have to get smarter. So one way for us to get inspired by how to innovate is we need a device intelligence evolution of sorts. Right now we're on the lower left corner, where really the devices don't do any error detection. They assume that the human operator is doing it correctly. And some of them would detect basic errors, and that's where most of the devices stop. So devices which actually measure something of the body. So really what we want is them to detect errors, detect and adapt to errors, and eventually if they become really smart, they become error and condition proof. No matter how you operate, you're going to do it right. Okay. This is another anecdote I heard talking to an higher official in a reasonably sized town. They're called towns in India. There are 2.5 million people. And they have, the whole town has only one spirometer in one hospital. And it is actually very very poorly used. I mean, in the sense it has very low usage, mostly because the waiting time is long. It is people don't want to go to a hospital, they would rather go to their doctor. And generally, that actually costs a lot for one test, by Indian standards, not by US standards. Okay. So again, that led to I started thinking about really in rethinking devices. We actually need devices to become more capable too, but cheaper at the same time. Okay. And so truly, actually, what we need, which is what the computing industry and communication industry has done beautifully, they actually have scaling laws. That means every other year, my computer will get twice as fast. So essentially, I think, and that kept innovation going. There was no proof for this, that the scaling law can actually work. But it kept the engineers inspired, and they have done it for decades. In a sense, we need something like that, where we are going to ask that every year you want the number of dimensions you can measure of human body, whether it's structural information or functional information, should double. Arbitrary number, but why not? Okay. Turns out that the basic reason why we play games is a challenge for invitation for unnecessary challenges, right? So this is, for engineers, this is like a game. I'm going to double how many dimensions I can get off your body, whether anybody needs it or not, who cares? We should do it, okay? And really, what does happen, we have seen from computing and communication industries, every time you double some capacity or computation horsepower, your actually cost of doing each individual operation actually reduces. So it's a great cost saving. Okay. So I'll give two examples. The reason I mentioned Spyro was because we had built a Spyro, which we were demoing to folks there, which doesn't essentially, basically uses the mobile phone to do all the error checking which a technician does. Okay. And since the type of errors which are happen in a spirometry maneuver are reasonably well understood, it wasn't very hard to do. So we built a custom Spyro. So that is a 3D printed case on the right side, and then Android app to go with it. And the objective of this design is, there are a lot of portable spirometers available in the market, is that this should be could be operated by a minimally trained person, hopefully by somebody who has no training at all. Okay. So, and then we always kind of, at least I believe that it should be a dual use technology. That means if it is useful, it should be useful here and useful there. So in fact, it turns out there are two trials we are headed towards. One for lung transplant patients who need 6 months of spirometry twice a day. But they actually only use peak flow meter today, which has 10% error according to ATS standards. And then the second would be in Hyderabad for finding cases in villages where healthcare workers would go from door to door, conduct tests. So this spirometer actually would find errors, detect type of errors. Like in this case, it shows that the maneuver had a hesitation or it was a short-lived maneuver. And then it will actually coach. So you can actually do context-sensitive coaching to correct those errors or help users actually deliver a right maneuver. I'll give one more example, and then I'll go back to my seat. So this idea of that you want to actually harvest more and more dimensions of human body, that means collect more information, and be adapt to more conditions, more error-prone conditions. Okay, so here is an example of actually we're building a retinal imager, which is an attachment to a smartphone, which will get clinical grade retinal images on undilated eyes. Okay, so right now, if you want like 45 plus degree field of view, you actually need to dilate human eye. Can we do it on an undilated human eye? And then as I said, we'd like to impose more and more conditions to keep engineers motivated. We want to do it with so that people with almost no training can operate this. So that leads to actually some interesting design choices and design challenges, which are included in the design from day one. They're not patchwork solutions later on. So we have actually already done some animal trials, and we just filed an IRB for human trials. So it's, that device is actually going to be clicking some human eye images soon. And then I will just this is the last slide. I just want to actually talk about one more thing. In fact, why did I even get into device research was this reason. Actually, we wanted to innovate on top of devices. So we said, can you just buy something that already exists in the market, and can I actually use them, the raw data, to do other things? I want to build smarts. Impossible. Almost every medical device, including the simplest ones, are actually completely closed interfaces. Okay. And if they are open, they're not calibrated. That means you have to do the calibration process itself, which itself is years of work sometimes. So definitely, and here I'm hopefully looking for, I hope there's some ideas. We would like to spur innovation. We want more engineers to participate in this. But we really cannot expect them to build all these devices from scratch every time. It's just a waste of time. But what version of open? I haven't figured out. We have actually played with many ideas. All ideas seem to hit either a legal wall or something else. And more importantly, are there good business models? Since I'm, I guess, in the business school, right? So business models which will spur open innovation. So I'll stop.
Great. Well, thank you, Ashu. With that call to arms, we'll move on to our next speaker, Lakshmi. So Lakshmi is an associate professor in the Courant Institute of Mathematical Sciences at NYU, where he does some really cool and interesting cross-disciplinary kinds of projects. He co-leads the Networks and Wide Area Systems Research Group and the Center for Technology and Economic Development.
So, three very good talks, tough act to follow. So if I want to start out with this, yeah, it works. If I want to start out with one summary in terms of business models and the entire discussion we have had so far, this is the one lesson that I've learned working in mobile health. There are three basic parameters: quality of care, access to care, and cost of care. And we're really, in distributed systems, there's something called CAP theorem, which is consistency, availability, and partitioning. In case you don't understand it, don't worry about it. But the basic point is pick any two, you don't get the third. If you get very good quality, and if you get very good access, the cost dimension gets hit. If you get very low cost, and if you get very good access, quality gets sacrificed. If you get very good quality and very good and relatively low cost, not everybody is going to get it. And it's basically a notion of resources. We are operating in environments where resources are either priced too high or resources availability is very limited. Now, the question with respect to the whole mobile health space is, if you bring in mobiles as an additional dimension, can they actually transform this landscape? So, if you look at access, there's been tons of approaches in terms of telemedicine, teleconsultation, and so on, that have tried to improve access, especially in the context of developing countries and so on. There have been some efforts at enhancing quality without too much compromise on cost. Certainly health records have helped. Actually, a big issue with respect to the cost equation is availability of medicine at relatively low cost. And there's been a lot of very cool tools on diagnostics that some of which Ashu shared with you. Now, lowering cost turns out actually to be a very hard problem if you do not want to sacrifice access and quality. And I think if you want to achieve all three and you have bits and pieces available today, the big question is, what is the right incentive structure? What is the right business model? More importantly, every person involved in the system has to get paid. And if you are thinking about doing healthcare delivery in Ghana, where we are giving HIV drugs for free, yes, it's a very interesting program and so on. But if you're figuring out the same program where you're charging a relatively nominal price, which is X% of their salary, it becomes a game changer. Even in the poorest of places in Bangladesh, there was a study that showed people were willing to invest 7 to 10% of their money for their own health. But they typically invest it when they get really sick. Maybe we could do it earlier. So what I'm going to share with you in the rest of my talk is basically two things. I'm going to delve. This is my larger message, but I'll start out with some success stories that I have encountered and I've had the privilege of being part of, and but I'll try to get back to this incentive question at the very end. So David mentioned about the Aravind Telemedicine network, and I was lucky to be part of the whole telemedicine deployment when I was a grad student at Berkeley and postdoc with Eric and so on. I continue to work with them when I was at NYU, and those are some of the graduate students climbing up towers, right? What did we do? Connectivity was a big problem, and we figured out a crazy way of making the Wi-Fi that you use in your laptops work over 400 kilometers. Don't ask me why we tried 400 kilometers, but in this case, we got it working over 20 to 30 kilometers, point to point. So we needed line of sight with directional antennas. And we were able to deliver about 10 megabits per second, which is really good for watching a very high quality Netflix movie. So we could do live video conferencing between a doctor in the main city and a nurse in the rural clinic. And this was a model where people paid 10 to 25 rupees, which is like less than $50 per visit for a basic eye checkup. And anybody with a serious eye condition was asked to go to the city for a quick referral. So it actually forced, and we had a whole bunch of statistics and two key takeaways. We were able to prevent a large number of people from potentially getting blind because of early treatment. And second, we achieved financial sustainability over a 24-month time period, which is crazy if you think about it. You set up a clinic in a rural place, you're charging them a nominal fee, and you're able to break even within a 2-year time period. And when I say we actually did nothing. Aravind Eye Hospitals did the rollout with the right incentive structure model. So they and they're now scaling it up to nearly 500,000 patients. So this is a massive program that's gotten a lot of attention and so on. Moving off topic, one of my students is now launching a startup on this idea on fingerprinting any surface. Why am I suddenly jumping into fingerprinting any surface? Every surface is unique. This cloth, this table, and so on. And by microscopically extracting the texture features of a surface, we can show uniqueness of the surface. And we are now working with the Met and MoMA to fingerprint artworks and so on. But that aside, this could be a big deal for health. Why? Because fake pharmaceuticals is a big part of the problem. And we believe that a technology like this, we are trying to make it really low cost. So the verification, we can get the verification device down to $20. And we are manufacturing some of them. They're coming down next month. At that cost, you could fingerprint every tablet. You could fingerprint the cover of a tablet. You can think about it, applying this in a lot of different ways for handling the fake pharmaceutical problem. An earlier project we had, Apothecary, had a slightly different take on the fake drug problem, which was how do you print random 2D barcodes on cartons, on pill bottles, and so on, and interconnect these random numbers in a certain fashion that you could text message the number. So there are existing variants like mPedigree and so on. So what we proposed was sort of an enhancement to some of the existing protocols, and we showed that you can actually do you can get pretty good security over the supply chain. That is, even if people try to bill for a carton or take specific boxes and replace, you could get some level of security, but it's not as secure as the fingerprinting of each tablet that I told you earlier. On a complete aside related to this, we worked with Kolebu on a third type of mobile app. In case people do not know Kolebu, Kolebu is one of the largest hospitals in West Africa, in Ghana. Again, Aravind, Kolebu, and so on handle 2 million patients per year, so these are like massive operations. And Kolebu had a particular problem where new drugs were coming in, and they wanted to monitor side effects. So this was the project that I was mentioning, where we actually spent 2 years trying to build a variety of different apps, and we were basically trying to get feedback from patients on potential side effects. So when a new drug comes onto the market, can they provide quick feedback on the drug and their potential side effects that you could track? This could be used for fake drug tracking in case there is too much pilferage, or if people wanted to get side effects information early. We had problems rolling out this particular project because of the TIA effect. It's called This Is Africa. So I have the privilege of being a participant in a project in Pakistan on one of the largest disease surveillance systems in the country. It's essentially getting data from a lot of hospitals and patients calling in. And the question is, can you predict an outbreak before it happens, 10 to 12 days before it happens? Now, there is Google flu trends, Google dengue trends, and so on. What we are really trying to do is, can we predict outbreaks at a block level? Can I take New York City and can I take Chelsea and can I say, is there an outbreak happening in Chelsea? So what is really happening here is that there's a hotline and people call in. And this was publicly publicized when they had their outbreak. And when people call in, they tell you their rough location. I mean, they could tell their full address, but we didn't want to know their address. And based on their rough location, you can get structured tagged information about various aspects of why they are calling in. So people could call in because there is a large swamp of water and they're seeing a lot of mosquito breeding. Or people could call in because I might be sick and I need to know, do I have dengue-like symptoms? So people call in for anything related to dengue if they're even suspicious. Now, using the structured tagged information, which is also location tagged, even if I get 5 calls from a block, that's huge evidence of a potential sign of an outbreak. So we are able to predict an outbreak roughly 12 days before using this data. And this is still unpublished, but we had to get the predictor system deployed. The cool thing about this particular effort is that they have a team of 2,500 health workers who act on these decisions. So the output is actually going to 200 hospitals and is going to this whole health worker. This is part of the government initiative, the PITB, whom we work with, Punjab IT Board. And they can actually go to these localities and they can also take pictures. So as a separate system, they are getting data from the preventive actions that have been taken in these. So it's not just sensing, but it's also, you're taking quick action. So at a really high level, 2011, they had an outbreak, and 2012, they ran this entire system, and though there was a sign of an outbreak, the intensity was much smaller. Now, is it because of the system or not? That is much harder to tell, but that's some early sign that things are looking much better. Now, shifting gears, we've had this discussion about all these projects look cool, right? At the heart of it, and I myself am, $5,000, $10,000 down on my own pocket, right? And this is a very personal issue for me, which is that yes, these are cool, and I would like to take them down on a possible startup commercialization path, because that's the skin in the game kind of thing. If you look at a lot of mobile health projects that have been funded and so on, and if you look at the CapEx, OpEx numbers of the mobile health company, something does not add up. And I just gave an example during one of my questions about the microfinance team we worked with in Mexico. Their CapEx turned out to be 0.72 million, and their OpEx was 0.75 million, just for a yearly operation of a mobile microfinance program. And that was the reason they decided to cancel it. So when there is funding, these projects go through. When the funding stops, you actually don't get sustainability. And you really want to get down to the game where a startup could go down there. And this is something we tried over a short time period, and I have to profess, we actually failed. But we tried to work with specific organizations to see, can we actually launch a mobile health startup? And we wrote down very interesting business models and so on. And we vetted it by business school folks and so on. But really getting it right is actually extremely hard. And even at that particular point, we could get customers who were willing to pay because they got funding to pay. But we never got a customer who was willing to pay because they really, really needed it. And that is worrying me a lot. So just to wrap up, to conclude on what David was saying earlier, sort of the vision for me is you have very limited resources. How do you design a healthcare system that optimizes the supply chain? And one of the things that we are thinking about right now is this concept of localized health networks, where a doctor, nurse, and a set of health workers form a team and are going to give healthcare delivery. And you need to basically ensure that everybody's time is constrained. And a patient who's going to come and see the doctor is only going to come and see the doctor when they have a serious problem. But the same patient could use a mobile phone and interact with the doctor and get early feedback. So how do you actually use a combination of mobile teleconsultation in combination with inpatient visits to actually build a system? And of course, electronic health records and so on needs to be part of the game because you need to keep track. So can you develop a system where, and based on this, if you get the system right, patients may even be willing to pay. If you can charge a nominal monthly or a yearly fee for participating in these localized health networks, where the fee is less than the transportation cost to the hospital, then they need to go. We can figure out a model. If you're interested, I can talk to you about exact numbers. So, thanks.
Thank you. Very good. So we have about 15 minutes left for questions. Don't be afraid. Over here.
I was just curious with the last, with the dengue fever. I didn't catch, but were people incentivized to call in about dengue kind of outbreaks, or did it just kind of happen?
So there was an outbreak going on, and this was widely publicized on TV channels. So anybody could call in to this number. So it was through publicity. And there was no particular incentive to call. The only incentive was that if you're feeling sick and you want to know whether you have any symptoms like dengue, please call. So I also feel that mHealth systems should be designed around incentives, where we can set up things like hotlines, or we can set up things like health workers going around and so on. But really, unless we capture the incentive structure of both the patient and the provider point of view, getting end-to-end execution right is very hard. And I think people like Aravind, eye hospitals, really got the incentive structure thought really, they thought it out really, really well. And they were able to achieve both sides.
While he's passing the microphone, let me just ask the engineers to think on a problem. This is a security conference, and I at least have not said a word about security. There's lots of innovation at the fringe. There are lots of people building devices to put stuff into the system. There are lots of people thinking about protocols. What people aren't focusing on at all, because nobody has come to you and said, do it, and here's a big check, is what's in the middle. And what we have is a virtual enterprise with lots of different players. It would be extraordinarily helpful if there were shared services in the middle, in the cloud, specifically rights management, first-class industrial-grade rights management, so everybody didn't have their own little system on passwords. That would recognize that they're different, that they're health workers and their clinics and their doctors and their hospitals and their people, and they have, so that if you think about a virtual enterprise model that would serve all these different NGOs and clinics and so on, that would be extremely helpful, because nobody's doing that today.
Okay. I was kind of wondering about this whole bit with the mobile health, reaching out to rural communities, and all these things are great ideas. And I see the bit with in India where you put up your own little telecommunication system. And I'm really wondering, are the telcos really taking the money they're making and investing adequately to allow us to move ahead?
Yeah. One of the concerns I have is that the people I work with in public health don't understand how fast industry is moving. So the great Gretzky said he scored well by going where the puck would be, not where the puck was. As a group, we tend to go where the puck used to be. So we're building systems based on crappy phones that only men have. But in fact, the networks are moving really quickly. As David said, that doesn't mean we have coverage everywhere, but in planning a system, assume we do. Not everybody has a phone, but in planning a system, assume we do. Not everybody has a smartphone, but in planning a system, assume every worker will, because if we don't give phablets or tablets to the health workers, we're making a huge systems thing. The industry's doing just fine. For us. They're building us a platform at no cost to us. What they're not doing very well, except in Kenya and a couple of other places, is leading the business model development. I hope that the gentleman who said earlier that Chuck said that the wireless industry was going to lead. I had hoped that. I don't think that's true. I hope it is true because they're well positioned to do that, but so far they haven't. But they have done their part well, which is build a platform.
Also in India, there is a national government-owned telecom, and they can be mandated to deploy networks. That's what Indian government has done, but like saying by 2015 or so, India should have 100% 3G coverage. And it is actually moving quite fast.
So here are some strange facts about telcos for the wider audience. People will not realize, but 60 to 70% of cell towers run on diesel. And if you think about the OPEX of a cell tower, sometimes the diesel cost is more than the money they actually make at a lower. So running, even as a business, running cell towers, the reason 3G connectivity or 2G connectivity does not penetrate into some of these low population areas is that the money they make is less than the money they can, is less than the money they have to invest in running it, because power distribution sucks. And it's not that power distribution is not there, right? A 220 volt power supply goes down to 150 volts, and Huawei equipment does not work. And Huawei is cheaper than Cisco equipment, so people use Huawei equipment. And trying to stabilize the power and so on, the efficiency factor is about less than 15%. So there are a lot of technical issues if people are interested in trying to make cell towers better. And solar power cell towers do not work because the cell tower power consumption is very high, and the amount of land area you need for stable and reliable solar is actually much harder. So just some fun facts.
We've also found in our system, we don't plan for synchronous communication all the time. That's one of the reasons we like tablets and phablets, is you can put the entire village on it, go out and have no connectivity, and then plug in when you come back. That's not everywhere I've been, there's been much better coverage than Lou's, but that doesn't mean it exists everywhere.
Andrew Campbell from Dartmouth College. I agree, cell coverage at Lou's is particularly bad. So I really learned from a lot of the points you made on the panel today. And maybe I'll take a feather out of Deepak's hat in asking you to project ahead. So the two short questions I have for the panel is, clearly, you know, the cell phone, cellular telephony is made the difference in the developing world, right? And it seems that to some degree, the developing world is way ahead of us in the developed world in terms of applying these technologies and you know, boots on the ground, and ideas are coming from there. So two questions. What do you think the major sort of barrier is to making a big advancement in this country in terms of mobile health? And secondly, you know, what can we learn from the developing world here in the developed world in terms of like bringing ideas back here?
I'm not sure it's way ahead. I think it's more, there aren't as many barriers because there's not, somebody told me once that said, why could God build the world in 6 days? And the answer was because there was no installed base. And I think that's the advantage in the developing world is that it's a kind of a clean slate. But most of what we're talking about are small demos by people. As he said, when Gates is paying or some of this, you know, we haven't figured out the business models to go to the base of the pyramid yet. There's lots of good stuff being done. There's lots of good technology, but there aren't transformed systems yet, because at least we haven't found the guy writing the check who says, man, I'd like to make my workers more well. You know, so I want to put this package together of nutrition and primary health and find the ones who have diabetes and keep them well. You know, and I'm doing that because I've got data that proves that I make money doing that. You know, we haven't got those kind of integrated systems yet. We've been doing proofs of concept so far for the most part. And so we can't bring back to this country and say, look, when you have an app that does CBT to deal with depression, and you make sure people have these nutritional supplements, and you measure full nutrition this way, and you do primary care this way, these are real results. And no, I haven't published it in the Lancet yet, but these are real results and they're online. We haven't done that yet. I think we can and will, but we haven't done it.
So just a couple of thoughts about that. I mean, one hand, if you look at what are the effective, I mean, from a healthcare point of view, applications, we do see some evidence now starting to appear, particularly in the areas of access to lab data and access to information on drug supply management. And so you comments about that earlier, both about counterfeiting and also the supply chain itself. But there are enormously cost-effective models in that, because the wastage that comes from, say, the drug supply chain is enormous. But one of the reasons why mHealth and some of the sort of leaner applications of eHealth are working now, I mean, just over the last 5 years or so, particularly well, is because there hasn't been an infrastructure before. So you've got a gap that you're suddenly able to bridge. So that's obviously potentially going to show a really big improvement in that system. Of course, it's much more complex in the US because you do have 5 or 10 different ways to communicate. You have these mail system, you have lots of kinds of phones and internet and so on. So the wins are slightly different. I think one example is community healthcare workers as a model for providing cost-effective healthcare particularly in chronic diseases. And that's something that is being shown actually in the US, for example, the PAC project in Boston that my colleague Heidi Kotz has been running, looking at complicated HIV patients with diabetes who don't manage their care well, getting a healthcare worker. And we also use ComCare mobile application to help support that. So I think there are models there, and Sonia Shin, another of my colleagues, is doing work with the Navajo Nation in New Mexico to support diabetes care. So that's going to be another thing where they're looking at how can we take some of these models and apply them, but again, in sort of somewhat disadvantaged, obviously very disadvantaged populations in those situations. But overall, it's still interesting if you look at the enormous gap in price for doing the same basic things. So I think there will be less in the US, but it's not quite as simple as just taking something.
One added point is, in the US, there's a very strict legal plus very structured, you have to go through very structured protocols and so on. And if you have to release a particular product, you have to go through clinical trials and you have to go. It's a very long way from innovation to actual market. And I think in some sense, if that can be shortened, that can actually change, that can be quite game changing. And the legal barrier is actually an important impediment in the sense that how do insurance companies interact with doctors, interact with insurance is coming right now in a big way in India. A lot of things used to be very low cost in India, but the same thing under an insurance model is much more expensive. So I can see, at least in some cases, the cost of care actually going up significantly. But the quality of care also significantly goes up. So to me, it's really like trying to figure out that sweet spot among those three variables. So.
Okay, so my question is about this idea of well care. I think that's a great idea. And then, you know, in the US, I work for Microsoft, and then company already subsidized for my gym membership. And then if I do some checkups and stuff, then I pay less for the healthcare premium and so on. And then if you look at app stores, there are lots of like fitness web stores and then, you know, Fitbits and stuff. So I can see that people are willing to pay for these kind of things. But since this session is about developing world, I'm curious how you can sort of incentivize either the ecosystem or the people so that those poor people, you know, who don't have enough spare money, willing to pay so that they feel better.
Yeah, let me give you a good example. When I was running the mHealth Alliance, we adopted maternal and child health as a goal, and we were going to aim at MDG 5. And so our goal was to reduce the deaths of mothers, and a little bit of MDG 4. If you do that right, you're going to reduce the deaths of kids. And the more we thought about that is how do you turn that into a product? Not dying is not a product. But the most powerful force in the world I've discovered from being married and having kids and having grandkids and watching my daughters is the power of a mother who wants the best for her child. So if you can get that Fitbit thing from Gold's Gym and translate that into, if I do these things for my baby, then their chances of going to IIT went like this. And you go to Hyderabad, it is full of private schools that are being supported by dirt poor people who are working 2 jobs so they can send their kids to school. So there is both incentive and there's money. If you can show them, this isn't going to make the kid feel better necessarily, but it's going to make the kid grow. And their kid is growing, and it's going to make the kid react better. And we can measure all of that, and the mother can see it on the cell phone of the worker, and can see that real full nourishment pattern, right feedback to her. Then I think we create a model. But this is just an I think, all right? I mean, we don't have the data. We have the data that says if you drink clean water, your baby's better off. We know that breastfeeding is a good thing. Did the breastfeeding people focus on nourishing the mother? No. So let's get that. You know, it's integrated systems that are focused on a successful baby, I think can help turn this around, just like integrated systems focused on workers who improve the productivity that we can measure.
I'll just
Okay.
take a quick European perspective on this and say that, unlike my friend David here, I do think the government has a role sometimes. And clearly when it comes to public health, it's very difficult to do a lot of that privately, but a community can often see an enormous benefit from an intervention that's improving some aspects of public health. And I think it was interesting that one of the things in Martin Weary's evaluation of the alerts was getting the underweight infants or children with HIV onto a nutritional program. And that they showed there was a much higher referral rate if you provided the reminders and warned them about the low body mass index. Well, that not only improves their outcome, but it also improves their brain development. And so, when you're applying different interventions, especially in infants and young children, you're really improving someone's lifetime abilities to think and to be, able to actually contribute to society. So, you're seeing in somewhere like Rwanda, where there's enormous improvements in healthcare, and particularly in children and pregnant women, that you're going to see a huge change, I think, in the economic outcome of the country in the long run.
Let me be corrected by my friend. I believe that we will fail unless government says, wow, this is the right thing to do. We need to invest the billions of rupees we're spending on school feeding programs the right way. So my focus on the private sector is to get them quickly, to develop the models quickly, to create consumer demand quickly, because if mothers feel that way about success, they will insist that government act that way. If the models are there, the government can be pushed to change its policies. But absolutely, we need to go with the government and get government involved in this. I just don't think they'll lead it.
Okay, we'll have one more question from Deepak.
I think I mostly had my question answered, but just very briefly, when you were talking about education, the question of incentives is hard because wellness is very hard to, you don't see results immediately. You don't see results for a very long time. And it's different from saying, well, your kid takes Adderall and they're suddenly studying better, which is probably what might happen quicker than going through all the...
I think you're wrong. I think you have a view of wellness that is given by the public health community who uses the word prevention, which I would never use because prevention is like trying to sell, not dying. There are aspects of wellness that have very short-term returns. Not fixing depression is a very short-term return. If you diagnose and treat depression, you can feel a lot better in a couple of days. I've been there, I know it. Lots of people have. Fixing malnutrition. If you're malnourished, you may not be perfectly nourished, but you're pretty well nourished. But if you're malnourished, you're going to feel the impact relatively quickly. So you're exactly right. But also, if we can show people data that starts showing that their body is going to produce this in the long run, people understand what these numbers mean and what that chart means, we can start creating demand even in advance of it right now, as opposed to just eat right and when you get to be my age, you'll live longer, which I agree with you is not a very compelling story.
Okay, wonderful. Thank you. It was a fascinating conversation. Thanks to all the panelists. And now we have a short break. We'll come back at 3:20 for the next panel.